Thank you very much for the kind introduction, and thank you very much for the invitation having me here. So, I'm a little bit in the unfortunate position of presenting something to the leaders of cancer screening in Europe without being myself a very expert of the breast cancer screening, but still I would think that the results of this work that we have done during the Can.Heal project will interest you, and I'm hopeful to learn also today. A little bit of context about the Can.Heal project that I was asked to present today in 1 minute, I promise. Can.Heal was a consortium that started in November 2022 and ended this year in April. It comprised 42 partners from 17 countries across Europe and had the idea of focusing on applying PLS and NGS technologies across Europe, building a cancer platform, a cancer genomics platform across Europe, especially on PLS and NGS. It was structured in 14 work packages and in 2 arms, genomics for public health and cancer diagnostics and treatment for all. Our role within the Can.Heal project was to deal with the work package 14, the healthcare system implementation under the coordination of Professor Stefano Boccia, which is a partner of EUCanScreen and also my mentor. The objective of the work packages was the production of recommendations for effective and sustainable implementation of personalized medicine into the healthcare systems. We had 3 use cases, which are the use of polygenic risk score in the prevention of breast cancer, the use of liquid biopsy in the management of advanced colorectal cancer, and the role of molecular tumor boards in the modern management of cancer patients. Of course, we will focus on the first one. So this is the group that had worked on this topic in our university, Università Cattolica del Sacro Cuore in Rome. And what are the recommendation challenges, basically? First of all, it's developing recommendation requires transparency, structure, and balance between evidence and patient values and the opinions of the healthcare leaders. It involves weighing benefits and harms, resolving evidence conflicts, ensuring consistency, avoiding bias, fostering collaboration, updating guidance to reflect evolving clinical evidence, and stakeholder input. What was our idea? To develop really rigorous and transparent recommendation about this topic was to use the great evidence decision framework, because it helps use evidence transparently and systematically. It clarifies judgments, supports dissemination, enables decision makers to adopt or adapt recommendations across different contexts and settings. Basically, the things that focus on the domains. The main domains are priority of the problem, benefits and harms, certainty of the evidence, balance between desirable and undesirable effects, outcome importance, resource use, equity, acceptability, and feasibility. So it's quite comprehensive. It involves having this kind of system with a panel that is at the center of the guideline development and gives its feedback to formulate the question with a clear pipe and rate the importance of the outcomes, and then again formulate the recommendation after the evidence review team has done systematic reviews and graded the evidence. The context of breast cancer in Europe is that by 2040 we will have 600,000 more cases and 173 3,000 more deaths. This is calculation by the ERC colleagues that have basically applied current cancer risks to the population structure that is projected at 2040. And of course, this is also the context of personalized screening with, in this case, the age-based guidelines that is represent one size fits all, and the personalized screening that can be a little bit more tailored, even though maybe this picture doesn't give enough credit to the standard age-based screening that has functioned very well anyways. What we can really do with personalized screening, I don't think I have to say this, basically in the context of breast cancer was the idea was that you can reduce the initiation of age screening, increase screening frequency, and intensify screening for people at high risk, and de-intensify screening for people at low risk. The question that was posed to us is should national or subnational systems in the European Union consider incorporating PRS either alone or in combination with family history versus standard of care used in organized breast cancer screening programs to inform these stratified screening strategies. This was the multidisciplinary panel with some colleagues that are here with us today. This was the final panel because Dr. Giorgiosi only joined in October 2024, while a colleague was removed from the panel because he was impossibilitated to participate and didn't provide his conflicts of interest. What was the Bible that was discussed during the first panel meeting? The Bible was basically, this was the proposal, adult women with minimum age 19 represented the population, the intervention for risk-based screening for breast cancer including PRS, comparison was standard of care age-based screening approach. The outcomes were the benefits or cause and breast cancer mortality, health-related quality of life, life year stay, autonomy control, and the arms were overdiagnosis, false positives, social emotional impact, cost effectiveness, and acceptability. The systematic review about the clinical utility of integrating the PRS was coordinated by Mark McCready at the University of Medicine of Hannover, and basically we realized that most of the evidence base for PRS-based screening was about diagnostic accuracy and predictive validity, predictive accuracy. So we asked the panel if it was more, let's say, important to focus on decision analytic models because of course the large trials that are currently ongoing and we have listened all day are currently not available, the data. So the modeling studies that were presented during the third panel meeting was this four: Van der Broek and colleagues, Fascian and colleagues, Wong and colleagues, and Antley and colleagues. From these four modeling studies we extracted the desirable and undesirable effect, and we calculated the certainty of evidence, the balance of effects, and the cost effectiveness. We used the question that has relevance and credibility of modeling studies for informing healthcare decision making from the ISPOR, and the grade classical system of inconsistency of results, indirectness of evidence, imprecision, and publication bias. The other domains were informed by two systematic reviews. Can.Heal was another partner of the project. Fortunately enough, we had a colleague that was in another group of Can.Heal that was developing these two systematic reviews at the same time, one that explored the stakeholder views and experiences regarding the PLS in critical settings, and one that analyzed the ethical and moral arguments surrounding the clinical application of PLS, highlighting key consideration for implementation. And she was kind enough to participate in our group to try to map these studies that she had found, she had identified within her systematic review to map to these other domains. What are the main results? What do the models really say? The first one is the Van der Broek and colleagues from the group of Professor Haddad. Basically, they use a US cohort to model an earlier start and adjusted intervals for women aged 30 to 50. They start their PLS that the model was based on the 313 SNPs, and women were grouped by risk, PLS percentile, and also family history. The strategies varied by start age and interval. And the main takeaway was that the earlier start to higher risk group is improved stats, averted and life years gained, but also raises false positive and overdiagnosis, and the best performing was combining PLS and family history to have largest gains with more arms, but trading off well, let's say. The second study that we have considered was the Wong colleagues in Singapore. This was a cost-effectiveness analysis. The strategies that they had modeled was around 3 months with low 60%. Low 60 percentile, mid 60 to 95 percentile, and high 95 percentile, start target at 35, and then having a tailored plan. They advise a long-term screening plan with the entity-intensified screening for the low-risk group, and in their analysis, this risk-based strategy dominated, both in terms of lower cost and higher quality, the age-based screening. Pashayan and colleagues in this famous paper from 2018 in JAMA Oncology basically modeled the intensified screening for people at low risk, and identified the 70th percentile as the threshold giving the highest net monetary benefit at threshold of accepting 20k pounds for quality. Without augmenting, without increasing the arms, without increasing worsening deaths of police. And then we also looked at the and colleagues in Lancet Oncology 2023. This was a cross-cancer model for PLS screening. They slice PLS into high-risk quantiles. For breast, basically they model extended screening to 40 to 49 for the top 20%. The results were modestly good compared to screening everyone age 48 to 49, so to extend to 48 to 49. And they called, this is from a group that normally calls for UK cluster randomized controlled trial for genomic screening. So the summary of findings was tabulated in these classical tables, one different for each of the four models, because of course the strategies were very different, so it couldn't make sense to make one table, one meta-analysis. The implementation domains were also tabled, and I go to the consensus, the last consensus survey that we had said that the problem was a priority. So, of course, the fact that it was a priority doesn't mean that necessarily we have to use a different approach. Desirable effects varies based on the context and the strategy as undesirable effects. The certainty of evidence is low to very low. And, but the balance of effects probably favors the interventions. So the cost effectiveness varies. Basically, we have found more evidence for the intensified screening than intensified screening. Okay, so it is more accepted that the intensified screening increase the cost effectiveness. Acceptability is probably yes, and the feasibility varies based on the health system. And the equity was probably reduced based according to 4 of the 5 panelists that have voted in the second round. So these are the preliminary, let's say, statements of all the categories. I will go directly to the recommendation. Should PRS-based breast cancer screening be adopted in the European health systems? Probably not yet, while we wait for the big, large trials to be completed and published. Of course, countries may consider pilot implementation in well-prepared health systems and using strict evaluation frameworks. Focus should remain on real-world evidence generation, equity monitoring, and ethical governance. And adoption should proceed where infrastructure, data protection, and professional readiness are established. Some stakeholder recommendations that I think are important is, for example, the integrate risk counseling in general into existing screening and primary care settings to avoid the genetic exceptionalism and have risk literacy. Moreover, the genetic literacy that is also useful. And the public and the citizens should be aware that the PRS-based screening is still under evaluation, and in any case is a complement but does not replace current screening practices, and they should expect transparency from the use privacy and the purpose of ongoing research. What the others say, basically, it's not very far from what we had said in the most recent guidelines from the this national and international organization. Of course, maybe the most interesting is the last one they say the current guidelines suggest that individuals with more than 20% lifetime risk based on models, including family history, should receive annual mammography and MRI screening. Of course, we also know that the NCCN guidelines are advised a lot for a lot of screenings and so on. So it's also, it's sometimes different from other organization evaluations. And this is all from my side. I'm eager to take your questions. And this is the group that worked on this analysis for Can.Heal and Università Cattolica. Second to the starting from the left is Tala, at the center Professor Stefania Boccia, and at the third left Eleonora Pascucci. Thank you very much.
Hi everyone, my name's Jonathan and I'm an academic clinical fellow in medical oncology. Thanks for inviting me to talk on liquid biopsies today. This is a field that I've been working in for the past decade or so, and I'm really sorry that I couldn't be there in person to present, but I'll show some QR codes so that you can contact me anytime. Very happy to discuss and collaborate. So I'll be talking about the use of liquid biopsies, which are blood-based cancer tests for the purpose of cancer screening, which is also termed multi-cancer early detection, and it's called MCED or MCED. I'll talk about the technologies that have emerged and the opportunities and potential challenges that these technologies face on their journey towards implementation for cancer screening. My academic and clinical work are both at UCL and the Crick in London, and on the right is a QR code through which you can contact me. Start with some disclosures. After working in the field for some years, developed methods for ctDNA detection, and that's also led to various startup work as well. So in this talk, I'll start by just outlining the biology of circulating DNA and where it comes from and why I think it's a good marker for cancer detection and monitoring. I'll talk about the technologies that have emerged for multi-cancer early detection. Then I'll talk about the potential opportunities and challenges that these tests face towards their goal of being used for cancer screening. As I'm sure you're all aware, in this particular audience, early detection of cancer improves outcomes, as shown here. The earlier you can diagnose someone with cancer, the earlier you can institute and implement kind of definitive treatments, such as surgery or definitive radiotherapy, before the cancer becomes more advanced, more heterogeneous, before it's spread throughout the body and allowed the metastatic process to carry on. And this is data from 2015, and I'm sure the data remains very similar now. Early detection is very important. So the marker which we're particularly interested in studying is circulating tumor DNA. This is DNA released from cancer cells when those cells die through a process of either apoptosis, necrosis, or maybe actively through secretion, although only a small proportion is secreted. They release their cancer DNA into the bloodstream, as shown, and each of their cancer mutations are represented in those DNA fragments. And so this lends it to be quite a specific marker of cancer, in that when you sequence their DNA and you identify these mutations or those specific methylation marks, you can say, oh, that must have come from a tumor cell versus not a tumor cell. This confers quite high specificity. This was something that we wrote some years ago with my PhD supervisor at the time, Nitzan Rosenfeld, and quite a lot of the slides I'll be presenting on are from kind of work that we've done over the years on this topic. At the time, we were thinking about what are the potential clinical applications of liquid biopsies, and the most exhaustive way that I could think about presenting it was through the cancer patient journey from diagnosis on here on the left all the way through to death. Liquid biopsies potentially have applications at almost every stage of the cancer patient journey, from early detection and screening, which is why we're here today, all the way through to monitoring, detection of residual disease, and then the study of how their cancer evolves on treatment. And really, there's been a lot of activity on the early end and also the later end of the time course of these individuals. So this is where I introduce the concept of multi-cancer early detection, as in screening tests using these liquid biopsies. And on the left, we show conventional current screening programs that are ongoing in the UK. And on the right, we show liquid biopsy-based MCED testing, which is now being assessed for its performance across a multitude of cancer types. For example, the GRAIL assay is potentially for dozens of different cancer types, albeit with differential performance across the cancer types. Some are shown here. One of the most popular biomarkers is this circulating DNA, although other assays exist that target circulating RNA, proteins, or CTCs, which are circulating tumor cells. So there's a lot of different competing technologies out there with different performances and also at different stages of their technological and clinical development. So again, yes, this is work that I did with Nitsan and also Peter Sassini, and both of these guys are now at Queen Mary or Bart's Cancer Institute in London. So one early technology that I'll start by outlining is the CancerSeq assay. This is an assay developed by a team at Johns Hopkins, and it targeted mutations in ctDNA, which are highly specific markers of disease, plus also a set of 8 proteins. And these are, say, conventional cancer proteins. So I think CA125 is in the list. Common cancer proteins alongside specific mutations for cancer. This was a proof of concept study. It was a retrospective analysis, and it was of, I think a few hundred individuals, just cases and controls. Um, Now, the issue with these case control studies in the liquid biopsy field, especially these proof of concept studies, is that the split between cases and controls is not really representative of true cancer screening. Because, say, if you have one-to-one case control, that's nothing like a true screening population. So it's something to consider in this early analysis. But nonetheless, they demonstrated a good AUC for cancer detection in their cohort. They showed that the sensitivity for detection increases by cancer stage. And you see here, stage 1 detection rate is percentage is 40%. And this is a number that sort of comes up over and over again. It's challenging for liquid biopsy MSEDs to get much higher than 40%. The Grail assay is about 20% for stage 1 disease. Others are, yeah, approximately that. And this really highlights one of the challenges in this field that's remained since the beginning, is this stage 1 detection rate, which I'll discuss a bit more later in the talk. Another aspect of these circulating DNA-based assays is that the detection rate by cancer type varies as well. You see here ovarian cancer here on the left with 100, well, nearly 100% sensitivity. You have to remember that some of the proteins are quite good at cancer detection. Although, yeah, may lack specificity. So here, the combination of the protein and the ctDNA may be advantageous, which is what this might be suggesting. But you have other cancer types which, say, just don't shed very much ctDNA, and down here on the right. So there's potential, if you were to implement such assays on as population screening approaches, you may have differential sorts of sensitivity, specificity performances across different cancer types, which also presents kind of challenges in itself. Aside from mutations and aside from proteins, the most recent generation of MZ tests are leveraging markers such as methylation or fragmentation of cfDNA. Here on the right just shows how you would detect tumor DNA using methylation. These assays would try and look for differences in methylation between certain fragments against others, by taking into account known methylation differences in those cancer types versus healthy. So that's kind of differential methylation-based analysis. Other assays use differences in fragmentation profile between cfDNAs, from cancer versus non-cancer. See here up here is just a schematic where fragment sizes differ between cases and controls. That was first shown maybe a decade or two ago, and since then that relationship really has held, and can be very useful for cancer detection, albeit not the most specific yet. Um, Now, there's a number of clinical trials that have emerged in recent times to assess the clinical benefit of multi-cancer early detection tests. Um, there's a lot of debate about the right endpoint for these trials. It's very much a balance between doing these trials quickly to try and learn about these assays in a time frame while that assay is still relevant because the field moves so quickly, versus again picking endpoints that are actually clinically relevant to patients. And here we provide some examples of the kind of main types of trial design. You might have a screening population where they undergo your MSED testing, and those which are positive may undergo investigation. Those which are negative just continue with standard of care. And this can assess the following outcomes, such as just diagnostic performance. This is non-randomized. And then in contrast, you can have randomized, there are randomized studies which exist, which I'll talk about in just a second, which randomize to either MSED-based testing or standard of care. And then you would then have MSED-based sort of investigation and potentially even management strategies. But this would require kind of study of long-term outcomes to compare whether or not it's superior. They've ended up having superior or worse outcomes overall. Here are the current studies in average risk populations that were prospective studies. When we wrote this paper fairly recently, really it's just 4 studies that we could find that were of average risk individuals in a prospective setting. It really narrowed it down quite a lot. And the assays used here in this table range from the cancer-seq one, which is protein and mutation, GRAIL, which is methylation. This CAN-SCAN one is this is a fragmentation-based approach using whole genome sequencing, and then this last one here is a combination of methylation, mutations, and fragmentation. So we will probably see MSEDS technologies becoming more and more complex over time because it's just theoretically possible to keep combining modalities using AI. And here, the performance is shown in this column here. We try to be as conservative as possible with our reporting of these assays' performance. And many of them, it wasn't possible to derive sensitivity or just based on follow-up or based on what they knew. But what we can say is on the whole, specificity tends to be between about 98, 99%-ish, which in itself poses a bit of an issue because you're gonna then have false positives that then have to go through investigation if you're really going to follow through with this. You also find stage 1 sensitivity can be a bit limiting. I've not shown it in the table, but the stage 1 GRAIL sensitivity is about 16% in one of their papers. So with a 1 in 5 sensitivity for stage 1 cancers, is that really enough to really move the needle in terms of survival for the population at large? So it remains to be seen. Nonetheless, there are opportunities for integration of these MSED tests into screening programs. They could complement existing screening programs by broadening out the tumor types that could be screened for, because many of these just simply don't have any screening tests available. They could potentially aid with the detection of existing cancer types that already have screening programs. Being liquid biopsy, being blood tests, they're repeatable, non-invasive, and there are quite a few logistical questions to iron out, other than the main one of, is this clearly beneficial for your population? Other questions that remain are, who should the target population be? Should it be just age-based, average risk? How often should they be tested? Many of the studies that I've shown previously aimed for about once a year. Is that the most appropriate? Is that the most cost-effective? Pathways, the clinical pathways that these patients would have to go through post MZ test would have to be established, and that would be a lot of work and also costly. Then also at the same time, the equity of access to these tests and also the psychological aspects of having these tests also should be considered. And I appreciate there is work going on in these areas. There are challenges of MZ tests. This is really early days. Here I've just listed both technical and clinical challenges. I've mentioned the limited sensitivity for stage 1 cancers, which is currently low. I think there's definitely scope for this to be increased over time with new iterations in technology, but again, remains to be proven. The accuracy of this TOO is somewhere between 80 to 90% for kind of predicting the top 1 or 2 tumor types, which again might be a challenge if you because it's going to lead to further investigations. And clinically, the false positives have implications. There's an unclear impact on survival benefit, which I mentioned, and also this psychological aspect. So there's still a lot of work to do in this field. Very briefly, I'm running out of time. Last couple slides. In terms of the future directions of the MSED field, how early can cancers even be detected using these liquid biopsies? Some studies suggest that it could even be years in advance of conventional cancer detection, which is quite an exciting prospect. So in summary, liquid biopsies may have applicability for cancer screening across multiple tumor types via these MSED-based approaches. The specificity is on the whole high, 98, 99%, but still that still poses challenges. The sensitivity is very much limiting for early stage disease, and this may hamper its ability to translate into clinical benefit. There is the potential for these assays to maybe complement existing programs, but it does require more, I think, likely more evidence and also next iterations of screening tests. Got a long list of people to acknowledge from my work over the years. Yeah, a lot of the slides that I've been showing are from work that I've done with Peter Sassini, Nitzan, at Queen Mary/Bart's Cancer Institute. If you'd like to contact me, here's a QR code. Really keen to chat more offline and potentially collaborate. Just, yeah, please do get in touch. And again, apologies for not being there in person. Hope you enjoy the conference.
Thank you very much for the introduction. As already introduced, I'm Jessie, currently a PhD candidate in the Netherlands at the Radboud University Medical Center. And during my PhD, I mainly focus on improving the interpretation of screening morphology, and I have a specific focus on AI. So today, I hope to be able to tell you a bit more about AI in screening in general. And I will first start off with 2 examples to show you what AI can already do, and then go into these 5 different topics, which I think are very important for a safe implementation of AI. So the biggest hype with artificial intelligence nowadays is, I think, in breast cancer screening, and then specifically for the detection of breast cancer. There have been multiple newspapers telling that AI is good in finding cancers, and research also has shown that the accuracy of the AI is on average similar to a radiologist. And actually, AI is not only research for cancer detection nowadays, but it's already implemented in some regions in Sweden and Denmark. And that's because they have currently a lack of radiologists. So they're really looking for ways with which they could solve this shortage. And AI was one of them. And I think because it's already implemented there, it's maybe nice to start with an example of what they're actually doing there. So they use AI for cancer detection, and they use the AI in 2 different ways. The first way is for decision support. So here the AI acts as a second set of eyes, helping the radiologist with highlighting regions that are malignant according to the AI, and then the radiologist can still make the final decision, decide to recall or not. So this is really a decision aid. The second way in which they're using it at the same time is to triage the examination to single and double reading. Because currently in these screening programs, each screening examination is interpreted by 2 radiologists, which means that there's quite a high screen reading workload. And because they have a shortage, they came up with this idea to make sure that the examinations that are highly suspicious according to the AI are still being looked at by 2 radiologists, whereas those that are maybe having a lower risk according to the AI might be good enough with 1 radiologist looking at it. So that's what they did to reduce the workload. So it was a combination both of decision support and triaging. And it's really nice, this is now implemented to also show what the effect of this is. And in Sweden there has been a big prospective randomized controlled trial linked to the SIDE trial, maybe some of you are familiar with it. And they did exactly what I just explained. So they used AI detection for decision support and triage to single and double reading. And they actually found promising results. Like expected, they found a reduction in workload, but actually they also found an improvement in cancer detection of about 29%. And importantly, this was without a significant change in the recall rate. So this looked quite promising. Then, as I told you, it is already implemented also in some regions in Denmark, and they also published results of screening performance right before and after implementation of the AI. And they showed similar things. So again, a reduced workload and an improved cancer detection. but this time even with a reduction in recall rate as well. So even with a workload reduction, there were fewer false positives and more detected cancers. Of course, these are short-term results. It would be interesting to also know more about the interval cancers, but this is what is so far being published, and I think that looks pretty promising. This was an example for breast cancer screening, as that's mainly my field of expertise also. But of course, you can also use an AI for different screening programs. For instance, to detect lung nodules on CT scans in high-risk lung cancer screening, or to maybe distinguish between normal and abnormal cells in cytology for cervical cancer screening, or maybe to help with detecting polyps during a colonoscopy in participants for cervical cancer screening. So this was just an example for which I think AI may help in the future to detect cancers. And the good thing about AI is that this actually never really happens, because the AI can continue 24/7. Unlike humans, the AI doesn't become tired, it is not influenced by the amount of hours of sleep it has, and it can just continue working. It will also always give you the same answer. So if you rerun it the second time on your image, for instance, you will get back the same answer, whereas for humans that is not always the case. Maybe nice to show you an example that is maybe a bit more affiliated with what we're talking about today, so personalized cancer screening, and that's to use AI for risk prediction. So I think AI might in the future also be able to predict the risk of a certain person to develop cancer in a certain time frame. And if we go back to breast cancer screening again, this may for instance be what it would look like, that if there were examinations with a high risk of developing breast cancer, it might be a good idea to have more frequent screening or shorter intervals, or maybe even use supplemental imaging like MRI. Whereas for the low risk examinations, maybe a longer screening interval might be sufficient. These are just some ideas. It's maybe still in the research phase. It is already shown that the AI models are able to outperform traditional risk models. They also can combine both AI and risk factors, and the results look good, but not as good as for AI detection yet. There is also not that much prospective evidence in breast cancer screening, as far as I'm aware, but I wanted to show you this Screen Trust MRI trial, which is again a trial with Sweden, and they did something similar. So this is not only risk prediction, because their AI score consists of 3 concepts. It was also cancer detection, like the previous example I showed, risk prediction, but also masking. So in mammograms, dense breast tissue can, for instance, mask lesions, and they also took that into account in their AI. So it's more than that, but still, if we would think about this AI score as a sort of risk predictor, what they actually did is they took examinations from women with a negative screening mammogram and checked what the AI said. And if the AI said that these women had a high risk of developing breast cancer, or that maybe breast cancer was detected in there, they randomized the women to supplemental MRI or not. And what they actually found was that in the supplemental MRI group, there were an additional cancers detected with a rate of 64 per 1,000. So even after a negative mammogram in actual screening, there were still quite some cancers detected in this high-risk group. And I think maybe AI might be a nice opportunity to decide who should go maybe for the supplemental MRI and who should not. These were 2 examples, so AI for cancer detection and AI for risk prediction. But I think before AI is implemented, it's very important that we keep track of these 5 different puzzle pieces. There's maybe more, but I wanted to highlight these 5. To start off with accuracy and risk assessment, because of course the first thing that's most important is to know that the AI is actually doing what you hope it wants to do. So simply comparing the output of the AI against the ground truth. In case of cancer detection, you hope to find as many cancers as possible and to have as many true negatives as well, whereas you want to reduce the number of false negatives and false positives. And I think this can be done on retrospective data sets, as long as you make sure that the data sets are a good representation of the entire world population. Because the AI can maybe be influenced by the things it's looking at. So different populations can give different answers. And to be able to generalize, I think it's important to include everyone, so there won't be bias. Besides populations, AI is also looking at something in terms of breast cancer screening is, for instance, the mammogram. So it's important to also take into account, for instance, different imaging systems. So you can think of that the AI might be influenced differently on systems for instance, Siemens than for Hologic. So it's important to be able to test the accuracy of the AI on different populations and different machines. If in the end it shows out retrospectively to be okay in use, we try starting some prospective studies, and that's what now I previously showed is already been done in Sweden and Denmark, at least for breast cancer detection. Then the second puzzle piece I wanted to highlight is trust, because even if AI shows promising results, I think it's still a problem of not being trusted. And I think this study nicely shows you this. This is a study done in breast cancer screening, and they asked the women how they would prefer their mammogram to be assessed. And as you can see, they actually, I'm sure if you can see. Well, the second one is one radiologist plus AI. So you see that the women actually preferred to have AI look at their exam together with one radiologist over two radiologists without AI. So there does seem to be some trust in that AI can have a benefit. However, the third line, you also see that they do not yet trust to let AI look at their examination on its own. So most women still prefer to have at least one human reader involved. And I completely understand that. AI is new, AI can also make mistakes, so can humans, but AI sometimes makes mistakes which we humans wouldn't make. And I want to show you an example of that. Because here you can see
5 minutes.
Oh, yeah, thank you. Here you can see a picture of a pig, which the AI correctly classified as a pig. But after adding noise, we can still clearly see this is a pig, but the AI now says that this is an airliner. I'm not sure why, maybe it has to do with the ears, but clearly this is not an airliner. And that's a problem if we want to get trust in the AI. Therefore, I think it would be important to have an AI that tells us I don't know. Because currently the AI will always give you an answer. Not knowing how certain it is about this answer, you have no idea if you're not looking at the images yourself. So I think it's important that in order to build trust, AI knows its limits and also can tell us about its limits. And there's currently already advancements which make some sort of certainty scores that tell you, okay, this is my output and I think I'm certain about it for this much percentage. And I think that can help to build trust. Even without certainty scores, I think it's also a matter of time to build trust, just like we rely on some machines. But in order to build trust, I think it's very important to be transparent and to communicate both the positive and negative effects of the AI. Although it's not easy. Going on to the third puzzle piece is regulation. I think it's very important that there is a regulatory framework. And since 2024, there is the European AI Act, which actually classifies different AI systems into different risk categories. And based on the risk category, there are certain requirements. So if you would take, for instance, in screening a high-risk AI system, which, for instance, detects cancers, you would have to follow these 4 steps. Of first developing a system, then undergoing some conformity assessment, registering it in a database so that we all know who is working on what, and getting CE approval before it can get on the market. And then whenever it is on the market, it's still important to keep on monitoring and informing about things that are happening. Then another important puzzle piece I think is training, because AI is new, and depending on how it's being used, I think it's very important to train the people that are working with it how it is working and how to interpret its results. And I think feedback can help with that. Because people may also change in the way how they look at AI and how they learn to work with it. And then the final puzzle piece I want to go to is monitoring. Because even if AI seems to work at the beginning of implementation, things can change in a program. There might be updates on the imaging system, the AI may change, the population may change, so it's very important to keep on checking this. You can both do that on a representative data set with the ground truth to check, okay, is it doing what I hope it is doing? But I think it's also important to check it prospectively in the program itself. And then depending on the timeline, you can both check short-term and long-term results. So for cancer detection, in the short term, you might, for instance, look at the distribution of the AI scores. Are they what you would expect them to be like, or are they off? And then maybe you should check what is going on. And on the longer term, this would, for instance, be looking at cancer detection and the different types. Are that the important cancers that are being found? And in the longer periods, there's of course the interval cancer rate. And I think these are important metrics to keep in mind once AI is implemented. Yeah, there were all the 5 puzzle pieces I wanted to tell you about, so I hope I was able to give a bit of an overview of what is happening with AI, at least in breast cancer screening nowadays already, but that there's also important things to take care of, both to make sure it's accurate, but also that it's trusted and monitored in the end. And then I want to thank you for your attention.